Let me ask you a question to start us off. Manufacture the most advanced scoliosis brace in the world today. CAD-CAM design, perfect trim lines, ideal pressure zones, everything textbook. Have I successfully treated scoliosis? I would argue no, not yet. I have made a very good product, but whether I have delivered a successful treatment depends on everything that happens next. Whether the correction is validated, whether the patient understands why they are wearing it, whether we are watching for the moment their growth outpaces the brace's fit. That gap, that gap between a well-made brace make this point far more convincingly than I can with words alone. For now, I just want this idea sitting in the room. The workshop builds the device. The clinic builds the outcome. So that was the part one. The argument that bracing is a process, not a product, and a look at where that process tends to break down. Thermoplastics, CAD-CAM software, a heat gun, and vacuum former. The manufacturing side of what we do. But here's what I want to highlight. Before a single sheet of plastic is heated, dozens of clinical decisions have already been made. What curve pattern are we dealing with? How much growth potential does this patient have? What's the sagittal alignment? What's the rotational component? Every one of those decisions happen before fabrication even starts. A brace does not make clinical decisions. People do. And those decisions, made well before the workshop, shape the final outcome far more than the material itself ever will. That's the reframe I want to leave you with on this slide. We are not primarily fabricators who happen to make some clinical calls along the way. We are clinical decision makers who happen to also fabricate. Let me walk you through what that decision pathway actually look like step by step. It starts with the referral. From there, clinical assessment, growth remaining, curve potential that feeds into understanding the curve pattern itself, sagittal alignment, rotation, which then shapes the goal of the prescription. What's the brace design? What's the brace concept we are going to build around? And running through all of it is patient lifestyle. Because the best clinical plan on paper still has to be on a real patient in their real life can actually live with. I want to be really direct about the point of this slide. This is not a manufacturing workflow. It's a clinical reasoning pathway. Every arrow you see here represents a decision, not a task to check off. And every one of those decisions influences the correction we ultimately achieve. Every box is a decision, not a task. So here is something I think we don't say often enough out loud. Delivery is not end of the treatment. It's the beginning of clinical management. Once that brace leaves the workshop and goes into the patient, the decision making doesn't stop. It just changes shape. Every fitting involves a constant balancing act between correction and tolerance. We are not just asking, can we correct this curve? We are asking, will this patient actually be able to live with this brace and wear it as prescribed? And that balance sits at the center of 5 factors we are weighing continuously: mobility, comfort, respiration, cosmesis, and pressure. Push too hard on correction and you lose comfort. You lose the patient's willingness to wear it. Compromise too much on the correction to keep them comfortable and you lose the clinical benefit entirely. Every adjustment, appointment is us renegotiating that balance. As the child grows, the spine changes, the brace's fit changes, and that whole balance shifts again. So we go back through it, reassessment, adjustment, follow up over and over for as long as they are in treatment. The workshop finishes the brace. The clinic finishes the treatment. We don't manufacture outcomes, we shape them, appointment by appointment, through clinical decision making that never really stops. Before any of that clinical decision making that we just have discussed and I have walked you through can happen, we need a standardized, structured assessment. This is the toolkit that underpins everything downstream. Cobb's angle remains our radiographic gold standard. It's what quantifies curve magnitude and guides our treatment threshold. Everything else builds on this number. Result sign tells us about skeletal maturity, which is critical for estimating progression risk and determining the timing of bracing. A result 0 patient and a result 3 patient are clinically speaking almost different problems. Adam forward bend test, supported by scoliometer measurements, give us an objective read on trunk asymmetry and rotational deformity. This is often our first clinical clue before imaging even confirms it. And then Lanky classification combined with side bending films. This is the one I want to emphasize because it's easy to over-rely on Lanky type alone. Side bending flexibility is often what actually determines whether a curve-specific brace like Providence or Charleston is appropriate or whether we need a full-time TLSO. Two patients with the same Lanky type and they can have different brace. Together, these four tools give us the framework for accurate diagnosis and informed decision making before a single clinical decision have been made. That brings us to part 3. I want to be upfront about something before we dive in. This next section is going to look on the surface like the brace types lecture I promised you at the start this talk would not be. 6 braces, their key features, their principles of correction. But I would ask you to listen to this section differently than you might normally. I'm not walking through these 6 braces to catalog them. You already know what a Boston brace looks like. I'm walking through them to show you the underlying biomechanical and corrective principle that guide when and why we choose one over another, and where the evidence is genuinely strong versus genuinely mixed. I'm going to tell you which is which. That distinction matters more than the catalog itself. So, 6 braces, 6 sets of underlying principles. Let's get into it. Here is the overview before we go brace by brace. All 6 of these sit under the umbrella of scoliosis bracing, but they split into genuinely different correction strategies. Boston brace, a 2-dimensional coronal TLSO. Milwaukee brace, a CTLSO for high thoracic curves. Charleston bending brace, a nighttime coronal brace. Providence brace, nighttime but with pseudo 3D elements. Rigoshino, true 3D correction. And kyphologic brace, which is a sagittal dominant for hyperkyphosis rather than pure scoliosis. I want you to notice the pattern here before we zoom into each one individually. Full-time versus nighttime, and 2-dimensional versus 3-dimensional. Those two variables, wear time and correction, dimensionality, are really the 2 axes that most of our brace selection decisions live on. Once you are clear on those 2 axes for a given patient, the choice of brace starts to narrow itself. So as we go through the next 6 slides, I would encourage you to keep asking yourself, where does this patient sit on those 2 axes? That's the lens I want you looking through, not just what does this brace look like. Let's start with the one you all know best, the Boston brace, a thoracolumbo-sacral orthosis. 2-dimensional and coronal dominant. It's indicated for thoracic, thoracolumbar, and lumbar curves. What I want you to appreciate about the design is the low profile. It supports the daily activity, which directly supports compliance. And compliance, as we are about to see, is not a minor factor. The correction principle is the classical 3-point pressure system, delivering targeted, frontal plane correction with some rotational control as a secondary effect. It's prescribed full-time, 18 to 23 hours a day. Now the evidence. This is where I want to spend a moment because the Boston brace carries the single strongest piece of evidence in our entire field for scoliosis bracing. The brace trial. Majority Boston brace cohort found 75% treatment success versus 42% with observation, an odds ratio of 4.11. And critically, success exceeds 90% in patients wearing the brace 13 or more hours a day. That number, 90%, is not about the brace design. It's about the adherence. It's the process argument playing out in a single most rigorous data set we have. Okay. Action combined with multiple strategically placed pads, giving us chronal correction with some sagittal effect. Though rotational control is limited, it's full-time, 20 to 23 hours a day. Now I want to be transparent with you about the evidence here, because I think transparency earns more trust in this room full of pianos than overstating it would. Milwaukee is the historical gold standard for high thoracic and cervicothoracic curves, but recent past decade comparative RCT data provide specific to this brace is generally limited. Most current practice has shifted toward modern CTLSO or TLSO alternatives for comfort and compliance, reserving Milwaukee specifically for the curves that a TLSO cannot capture. I would rather flag that evidence gap myself than have any of you ask me about it, because I think you would be the right to ask. So the next one is Charleston bending brace, our first nighttime brace in this lineup, and a nice contrast to what we have just covered. It's indicated for single lumbar or thoracolumbar curves. What makes it distinctive is the correction strategy. The patient is overcorrected while supine, side bend towards the convexity of the curve. That correction is amplified purely through rest, worn roughly 8 hours a night, with no restriction on daytime activity at all. Because it's chronal dominant and correction is limited when the patient is upright, it's a two-dimensional brace with only minor sagittal influence. The evidence here is genuinely strong. And this is also one of my favorite braces. A systematic review and meta-analysis of 33 studies found a pooled success rate of 78.7% for nighttime bracing versus 50% for observation. And I want to flag something specific. Outcomes were best in thoracolumbar and lumbar curves, and in patients who started bracing at reserve 1 or 2. That's not incidental. It tells us exactly what patient this brace is actually built for. A separate long-term Charleston-specific cohort, 98 patients reported 66% success, with 17% eventually requiring surgery, consistent with what the meta-analysis would predict. So, for the right curve, in the right patient, at the right skeletal maturity, this is a genuine reported option, and one that asks for less than a child's daily life than a full-time brace does. So the next one we have is the Providence brace. Another nighttime option, curve specific and designed to deliver correction while the patient sleeps, much like Charleston, but with a different mechanism. It delivers lateral and derotational forces while the patient is supine. Correction is amplified through targeted overcorrection in that position. And it incorporates what often called pseudo 3D correction, addressing a minor rotational component on top of the primary chronal effect. Now, this is a slide where I want to slow down because I think intellectual honesty matters more here than anywhere else in this talk. The evidence on Providence is genuinely mixed. And I don't think we do ourselves any favor by pretending otherwise. One study, 358 patients, found the Boston brace outperformed Providence, 59% success versus 46%. A separate randomized cohort analysis found no significant difference at all. 71% versus 65%. And a Danish RCT found comparable progression between the two, though it flagged more severe progressors specifically in the Providence arm. What I take from this, and what I would encourage you to take from it too, is that patient selection, not the brace itself, appears to be the deciding factor here. Providence is not a brace I would rule out, but it's one where I would want to be especially rigorous about who I am putting it on, and especially disciplined about follow up. Precisely because the evidence that we have doesn't let us coast on confidence the way Boston or Charleston does. The next comes Rigoshino brace. This is the one I would call the most biomechanically ambitious brace in this lineup. True 3D correction, the asymmetrical design, with its expansion wires, addresses coronal, sagittal, and transverse planes all at once. What I find clinically interesting about this brace is that it doesn't just passively hold the curve. It encourages active postural engagement. The patient is participating in their own correction, not just being constrained by it. It's a full-time wear. And the evidence backs up the ambition. A retrospective study of 108 patients found Rigoshino orthosis patients had significantly lower rates of spinal surgery and less curve progression than matched Boston-style TLSO patients, despite similar baseline curves and similar wear time. That last part matters. This is not just patient who wore it more did better. Wear time was the control for. But here's the finding I actually want you to remember from this slide because I think it's the most clinically useful one. In RESERVE 0 patients, specifically, your least mature, highest risk group, Boston brace patients had 5.6 times the surgery risk compared to those in Rigoshino brace or Providence. The advantage of this brace concentrates precisely where the stakes are the highest. So if I'm looking at a very young, very immature patient with real progression risk, this is where Rigoshino earns its complexity. The last of our 6, and a bit of a departure, because this one is not correcting coronal curve at all. The kyphologic brace is sagittal plane dominant, built for thoracic hyperkyphosis. Scheuermann's disease being the classic indication, the design uses segmented pressure zones combined with anterior expansion areas, applying controlled extension forces through a sagittal 3-point pressure system. It's full-time wear, and while the primary focus is sagittal, it does carry secondary 3-dimensional postural effect that supports overall spine alignment. I actually have the real data on this one that I was pleased to find because it's not always easy to source for this specific brace. A cohort of 56 adolescents showed a mean in-brace correction of 16.5 degrees, a 30% reduction from baseline, typically significant, less than 0. And that correction is comparable to what Milwaukee brace has historically achieved for hyperkyphosis, which we know translates to favorable long-term outcomes. Here's the connective thread I want to draw for you before we move on. That greater than 15-degree in-brace correction threshold is the same benchmark we use to predict in coronal scoliosis braces. Same underlying principle. Early meaningful in-brace correction predicts long-term success, just applied in a different plane. It's the same argument, showing up again in a completely different curve type. That's actually a nice bridge into where we are headed next, bringing all 6 of these braces back together under one clinical philosophy. So now that we have walked through all 6 braces individually, I want to zoom back out and synthesize. Because here's the thing I hope has come through by now. Advancing bracing is defined not by the brace we choose, but by how precisely we apply and refine it. There are 4 principles that cut across every single brace we just discussed, regardless of which one you are holding in your hands. Curve-specific customization, pattern recognition over routine practice, curve type, magnitude, flexibility, skeletal maturity. Every one of those inputs should be shaping brace selection, not just a lanky label. 3D correction strategy. Even braces we think of as primarily two-dimension, like Boston, are addressing frontal, sagittal, and transverse planes together through careful placement of pressure zones and expansion walls. Nothing we use is purely one-dimensional, but here one thing to remember, if it is designed well, only if it is designed well. Dynamic adjustment approach. Braces are not static objects. They have to be modified over time for growth, for curve progression, for patient tolerance. A brace that is not being actively adjusted is a brace that's slowly falling out of date and its own patient. In brace correction optimization, and this brings us back to the thread running through this entire talk. Maximize achievable correction and use in-brace imaging as a decision-making tool, not as documentation you file away and forget. These four things, not brace choice, are what separate a mediocre outcome from an excellent one on identical hardware. So, with all of that principle and all that evidence is behind us, why does bracing still fail in real practice as often as it does? I would argue it comes down to four recurring failure points, and none of them are really about the device. Poor prescription. Brace selection not aligned with curve pattern, flexibility, or sagittal profile. This is a decision-making failure right at the very first step of the pathway we discussed back in previous slides. Inadequate in-brace correction. Either it's never actually validated radiographically, we just assume it's good, or it's limited by suboptimal optimal force application at the fitting stage. Either way, we are flying blind on the single strongest predictor we have. Lack of active follow-up. Bracing gets treated as a one-time intervention. Fit it, send them home, see them in next 6 months. Rather than continuously managed process, it actually needs to be. Compliance gaps. And I want to push back gently on how we usually talk about compliance. It's not about just like about the wear time. It's driven by comfort, by understanding, by genuine engagement. A patient who doesn't understand why they are wearing a brace is not going to wear it consistently, no matter how many times we tell them to. Did you notice something about all four of these? None of them are fabrication problem. Bracing doesn't fail because of the device. It fails because of the process. That's the sentence I would want you to leave this slide with. This is where I want to bring everything together. Because when we treat bracing as a process, outcomes stop being variable. They become predictable. That's not an aspiration. There's a real data behind that claim. And I want to walk you through the three numbers on this slide. First, in a cohort of 1,050 patients, in-brace correction increased the odds of ending treatment below 30, 40, or 50 degrees by 30%, 24%, and 23% respectively. This is a dose-response relationship. Those who are in research, they can relate with this term. More in-brace correction, measurably better odds at every threshold we care about. Second, 87% bracing success. When a low result sign and high in-brace correction aligns, that's our highest risk patient, the one we would otherwise worry about most, achieving some of our best outcomes when we get that early correction right. Third, the one I find genuinely striking, an area under curve of 0.908 for adherence as a predictor of short-term outcome from real-world sensor data, not self-reported wear time, actual sensor-verified adherence. That's about as strong a predictor as we get anywhere in clinical medicine. And that translate into 4 practical principles I would ask you to carry out of this room today. Match brace design to curve behavior, not just its classification. Because curve with the same label can behave completely different. Treat the in-brace X-ray as a decision-making tool, not a formality you file away. Understand that compliance is engineered through education and understanding. It cannot simply be instructed. And accept that bracing is a dynamic intervention, requiring continuous reassessment, not a one-time fitting. This is the whole argument of the talk, distilled into 3 numbers and 4 principles in this slide. Everything I have told you so far has been the literature, meta-analysis, other people's data. I want to close this argument with something different. 3 real clinical cases from my own recent practice. Because I think they make this point more convincingly than any citation I could put on this slide. Case 1, 10-year-old female, idiopathic scoliosis, treated with Rigo brace. On the left, her spine without the brace. On the right, in brace. You can see the coronal correction immediately. This is not a subtle difference. Case 2, also 10 years old, also idiopathic scoliosis, but this time treated with Charleston bending brace. Again, without brace and brace. This is the supine. That's why you can see a little bit, pelvis level difference.
मैडम सॉरी मैं आपको इंटरप्ट कर रहा हूँ. ये जो लिंक है तकरीबन 7-8 मिनट्स में ख़त्म हो जाएगा. अगर लेक्चर तक ख़त्म होता है तो ठीक है, नहीं तो फिर एक नेक्स्ट लिंक बनाएंगे.
Okay, sure. So again, the second one, we have given Charleston bending brace. We can see with brace and without brace X-ray. Nighttime overcorrection we discussed earlier, and you can see it is stabilizing this single curve effectively. Case 3, 16 years old female, idiopathic scoliosis, Rigo specifically E1 type design. Here you can see a more robust 3D correction, including both the frontal and rotational plane, which is exactly what we would expect from this brace design in an older, more complex curve. Across all 3 cases, what I want you to notice is the same pattern. Maximizing in-brace correction correlates directly with the trajectory these patients went on to have. In-brace correction is the first true indicator of clinical success, not the final one, but the first and arguably the most important early signal we get. This is the precision, patient-specific bracing, producing real, measurable results, not in a journal. This is from my own clinic. It brings me to the end of the formal part of this talk. I would genuinely like to open the floor now. You can write your questions in chat box, and I mean that more than the usual closing line. So let me point you towards a few places. If you don't have any other question, I would specifically welcome pushback. I gave you a working number today, roughly 50% in-brace correction as a floor. I know practice varies by setting, by patient population, by what your surgeon expects. Where does your own threshold sit, and what's shaped it? I was also deliberately upfront about where the evidence is thin. Milwaukee's recent data gap, Providence mixed trial results. If you weigh that evidence differently than I did, I would rather hear it from you now than have it sit unspoken. And on the communication with referring surgeons, I know that relationship looks different depending on your situation and your institution. I would like to hear how it works or doesn't in yours. So you can ask your questions now.
जी, आप अपने चैट बॉक्स में अपने क्वेश्चंस कर लें, मैडम वहाँ से जवाब दे देगी आपको. और मीटिंग का ये जो लिंक है ये 5 मिनट्स में ख़त्म होने वाला है. मैं एक और लिंक बनाऊंगा, उसमें फिर आप लोग अपने क्वेश्चंस कंटिन्यू कर सकते हैं.
Okay, meanwhile, we will have more questions. I will just move it towards the end. I want to leave you with one last thought before we close. A brace corrects a curve in weeks. A clinician corrects a course of care over years. Through every decision that happens before, during, and after the plastic is shaped. That's really what today has been about. Not asking you to choose different braces or distrust the one you have already used very well. Just asking you to notice how much of what determines a patient's outcome happens in this room, in the follow up visit, in the conversation with the scared 10 years old and their parents, not on the workbench. If there's one thing I would want you to carry out of this meeting today, it's that shift in where you look when something is not working. Not what's wrong with this brace. Ask where did the process fail? That question has changed how I practice, and I hope it does something similar for at least a few of you. Thank you all for your time and your questions. You can ask through NAPO team or you can ask through the LinkedIn. Having this first session met with such a genuine engagement means a great deal to me. I also want to thank the NAPO team for making this possible, and especially the leader of NAPO Overseas Cabinet, Mr. Sikandar, in taking this initiative. If any queries comes to mind after today, feel free to connect with me on LinkedIn or reach me through the NAPO team. Thank you once again. We can wait till this session ends. And if we have any question, Ashad, we can start the new one. Otherwise, we will just close here.
ये मीटिंग ख़त्म होने वाली है, बस इसको मैं क्लोज करने लगा हूँ। एक और लिंक मैं आपके साथ ग्रुप में शेयर करने लगा हूँ, उसको आप ज्वाइन कर लें और वहाँ पे मैडम से आपने क्वेश्चन कर सकते हैं। शुक्रिया।
The question that we have now for the windows, these are basically expansion voids, and these are exactly opposite to the pressures, and these are necessary for the breathing, for respiration. And if you know regarding the short physical therapy, it's best to be done within the brace. So they are the therapists, they are doing this within the brace and without the brace both. So the expansion voids typically help them to do that, because they can see the respiration. It's easy within that brace. What features make a Rigo Shino brace different from simple Shino brace? It's the same. Rigo Shino brace. Rigo is a scientist. Is like an inventor who invented this. What is your thoughts on exercises and physio? Does it play important role in correction? Of course, 100%. They do work in parallel. Like if we are giving the brace, it's like multidisciplinary approach. We are giving the brace and we will ask them to do physiotherapy. Especially, I will recommend short physical therapy. You will get the best results with this one if they go hand in hand. So, of course, it is very important. Any more question we can see here? I cannot see. Okay, we have one more question. What will be your approach for the neurological condition with poor compliance and high tone? What type of brace you will recommend? For neurological condition, basically if they are bedridden particularly, our approach will not be, of course, the correction. We will just first control the symptoms and the alignment. So not to worse the symptoms or the situation. Mostly in my cases, I have gone towards the Boston design for that, because we don't want rigorous correction for those neurological condition and poor compliance patient. And of course, if they are high tone as well. So in my cases, I'm preferring basically Boston brace for that. And we need to keep in mind that we cannot, we cannot, overpass the comfort for correction. And we need to specifically think for these neurological conditions. Did I answer all these questions? If you have any more questions, please do let me know. I'll answer them.
किसी का अगर कोई क्वेश्चन रहता है तो आप कर लें, अगर नहीं तो फिर नासर सर व्हाट ऑफ थिंग्स करेंगे.
Any more questions?
आई थिंक सर कोई क्वेश्चन नहीं रहते हैं. NAPO president will now take the stage.
We have one more question. If a shunt is inside, would you recommend a brace?
For this one, it depends. We need to know the more history for the patient. We need to do a proper physical examination. Can you share more details for this patient if we have a particular patient for this?
Oh, basically this was a question from someone, so I don't know.
Okay. So if that's a rehab patient, bedridden patient, of course we'll go for simple Boston just to to do the alignment, to control the symptoms, and we will make a window at that particular place. But of course we need to know the more about this patient. We cannot just just on based of this shunt, we cannot decide the prescription. I cannot see more question actually.
I think it's over.
Okay.
And, yeah. Azad?
Yes, thank you all.
Closing remarks देते हैं और उसके बाद फिर इंशाल्लाह उसको वो करेंगे. First of all, thank you, Ms. Sidra Manzoor Cheema, for your insightful and deeply impactful presentation on scoliosis. Your dedication highlight exactly where our overseas cabinet is so vital for our global mission. Thank you very much, and thanks to Sikandar Bhai, our cabinet overseas cabinet lead, for taking initiative of this NAPO Insight, and thank you to our team as well, Mr. Azjad and Ms. Laiba, to make this happen. And thank you all the participants. Today it shows hunger for learning. So hopefully we will continue such presentation and webinars. And our mission is that we have to spread knowledge and discuss the important clinical practices that are especially from our overseas cabinet. We connect both the Pakistani PNOs and to the world with this overseas cabinet. So it is very important and very crucial. And the presentation was outstanding. I'm very happy. Thank you all. What I can say more.
Thank you.
Thank you, Ms. Sidra again.
ऐड करना चाहता है.
Thank you, Mr. Nasir Ahmed, for leading this NAPO with such dedication, and it's my pleasure to be part of it. Thank you so much.
Thank you. Thank you.
Assalamu alaikum, everyone. I think Irtizab, I have one last question, Sidra. So if you can please answer that, and inshallah, then we can conclude the session.
Actually, I cannot see the question box. Can someone read it?
So the question is about the spinal bracing regarding the spinal cord. That's the question, actually. He's asking about your opinion about the spinal cord.
The spine cord brace? Actually, yes. I haven't used this brace, but I have heard about this one, that it's more flexible in comparison to the braces that we have used, but I didn't experience spine cord. I would love to do it for my next patients. We will see. But I can just, give you some information through the literature that we have, but I have no, if they are asking my personal experience, I have no experience with this brace till now. Maybe in future, then I can answer this better.
एक क्वेश्चन सुंदस अब्दुल वहाब का भी है, अगर वो कर सकती है, and we will end the session then.
Yes, please take this question. Asad, you have to help me, please, because I cannot see the question here. It's just closed. I cannot relocate the questions.
Can you hear us?
Yes, the question is here. A 70-year-old lady with osteopenia and osteoporosis, albeit lumbar-vertebral 2 fracture, focal kyphosis, what would be the appropriate spinal brace for her? It's somewhat like not related with scoliosis, but yes.
Yeah. Okay, so for this, we will go for, like, it depends on what is the, prescription by orthopedic surgeon as well. It do plays a role. We need to check, like, if they just want to stabilize or they just want to immobilize it. So we do have like off-the-shelf solutions for this. We can go for that. They do have like aluminum panels that we can just like mold according to the contours, and it can give the best like possible immobilization and stability. We will not go for, I think this is not, of course, the scoliosis related question, but
Yeah,
for the
yes.
spinal bracing, we can go for off the shelf. We can take more questions in WhatsApp group, or you can send it to our NAPO team. We will answer all your questions, even if you will get to know it later. If you have more questions later, no problem. We will take them all. But as we are running out of time, so I think we should conclude it. Asjad, over to you, please.
Thank you, madam. Insightful session, and thank you all for joining it. We will have more and more sessions. Thank you all, and good night.